biofilm in wound healing today. This was a webinar that I had given at Association of Physicians of India, Rajasthan's chapter meeting on 27th of December, and we'll quickly talk about this as there was a request for this video recording. My conflicts are nothing but removing barriers to healing for infection, wound care, and obesity. And I do have telemedicine involvement with a startup company. And also, basically, my social media contacts are at Wound Physician, and the hashtag that I mostly use is removing barriers to healing. With that, we'll start the recording. So the objectives of this discussion would be factors contributing to diabetic ulcer chronicity, and biofilm-based wound care, role of bacteria, and discussing the International Working Group Diabetic Food Guidelines, and also to investigate emerging research regarding different biofilm penetrating techniques, and also leverage biofilm disrupting technology and therapeutics for chronic wounds. And as we know, wound care is very much needing wound bed preparation. This wound bed preparation is done majorly by debridement, exudate management, and bacterial balance via infection control. And the time techniques wherein tissue, infection, inflammation, moisture, and edge are used, but also the techniques, the criteria called NERS and STONISH, which most wound care providers understand, are being used. Like 3 of each are supposed to be for acute and chronic wounds. But also we need to understand that pressure, nutrition, and offloading are very much need to be focused on. So the 4 major pillars for chronic wound pathogenesis are hypoxia, reperfusion, injury after ischemia, and also intrinsic host factors, which are multiple. But we'll focus today on nutrition and biofilm, infection and biofilm, whereas nutrition was a whole another topic. Biofilm is a community of pathogens that are enveloped in a complex structure of polymers strengthened with metallic bonds. But what happens in any kind of wound, whether it is diabetic, arterial, venous, traumatic, or pressure ulcer, is the wound gets stuck. And normal wound healing is a complex sequence, as we are aware. But inflammation is a major part of it, and influx of bacteria into the biofilm changes the healing cascade. And these bacteria are enveloped in an extracellular polymeric substance that increases the inflammatory process, stalling the wound healing and causing the traditional wound care healing processes to be ineffective and putting the wounds into chronicity. So these chronic wounds are still are needing wound care aggressive treatments, and this biofilm are noted to be present in chronic wounds in 60% of them at least, and even in 6% of the wounds have this problem. And basically we'll go through the different etiologies and conditions that would how to deal with this problem. So in the sequence of wound healing, basically chronic wounds get stuck in the second phase of wound healing, which is nothing but inflammation, which comes after hemostasis, and rest of it is repair and remodeling. This is classical picture that is being quoted in many wound care processes. Obviously, we are aware of that. The biofilm, by definition, is a surface-associated microbial community that is composed of various phenotypes and genotypes that encase itself in a 3-dimensional matrix of extracellular polymeric substance, and that demonstrate increased resistance to cellular and chemical attacks. This theory was predominantly started around 1978, with 99% of bacteria growing on surfaces, and many bacterial biofilms are present everywhere, including the harsh environments of ocean and deep groundwater, even in the Antarctic and Arctic area. Deep digging of cold, deep ice digging also had this bacteria in the biofilm. So as you can see here, biofilms, in fact, many industries, including oil industry, ship hulls, medical processes, and even drinking water in the teeth. So in the human biofilm infections, you can see it in endocarditis, arthritis media, prostatitis, cystic fibrosis, periodontitis, and obviously chronic wounds, which we're going to talk today, but also medical devices, including IUDs, central venous catheter, prosthetic heart valves, and multiple areas of healthcare are being impacted by this biofilm. What is biofilm is this is a conceptual cartoon that you can see here, wherein the basic structure has a cell cluster with the multiple channels, and it is a microcolony wherein cells are living and hydrated, and also cells have towers and and there's a communication channels that are present. So how does this happen? When the free-floating planktonic bacteria come in attach to an inanimate object, then they produce slimy material, which is extracellular polymeric substances on the surface, and these grow. And after a certain time, they start clumping together and form enough size of a colony and start causing seed dispersal. And then this also happens because of cell-to-cell signaling. Now, initially the cells form, but then something called as quorum sensing we're going to talk about in a bit, but also then mature biofilm forms, wherein it's a process wherein the quorum sensing is a process wherein the bacteria communicate with each other. This happens through a molecular language that the bacteria speak. These are called autoinducers, wherein these autoinducers for gram-negative bacteria are called homoserine lactones, and for gram-positive bacteria called oligopeptides. But all the bacteria talk to each other through a common language that is called autoinducer, which is the universal molecule that is a common communicating molecule. So bacteria do talk. Different bacteria of different kinds do talk to each other. Sometimes humans don't. That's a major problem in healthcare and everywhere, I guess, for humans. Now, most of the bacteria are thought to be in the surface, but in reality, only 10% of them are in the surface. 90% of them in the deeper areas, just like an iceberg. So what happens is initially the antimicrobial biofilm mechanisms of tolerance would be like slow penetration, but then once you clean them up, there could be other bacteria that are living that are kind of in the altered microenvironment, and still there's certain other bacteria that could be slow persisters. That is, these bacteria that survive on the deeper aspects of the tissue then tend to survive, like persisting bacteria after antimicrobial therapy. Now, we need to understand that there is a significant immunological response to any foreign material in the body. Now, in this panel A, you're able to see that the antibodies and phagocytes are trying to get to this microbes, but over time, the microbes form a colony, and then that's when the neutrophils start coming to this area. But the neutrophils come here, and they are not able to do an effective job because of the nice extracellular polymeric substance that the bacteria are encased in. And but then the neutrophils cause the trouble with release of proteases and reactive oxygen species. These neutrophils then accumulate, and then there is increased release of all the inflammatory molecules, causing infection in the neighboring tissue. So biofilm, as you can see here, is enveloped here with a metallic bond in between, and there's multiple extracellular polymeric substances that are present, but most of them are encased. Only 10% of the bacteria are really free floating. So we need to understand the concept of dynamic reciprocity, wherein the the cells and extracellular matrix are dynamically interacting with each other in the local microenvironment, which involve different growth factors and cytokines. And the extracellular matrix then influences the cell, which influences the genetic expression, which in turn influences the extracellular matrix again. So normal healing wound bed really needs a significant interaction between these extracellular matrix and cells to happen for adequate healing. Now, why is that? Because wound healing happens when controlled inflammation is present, wherein the inflammatory cells kill microorganisms and release MMPs and elastases. Controlled MMPs are needed to help with removal of the denatured matrix, to degrade the cellular basement membrane, for contracting of the extracellular matrix by myofibroblasts, migration of epidermal cells, and scar remodeling. Any wound that fails to proceed through the normal healing process gets stuck in the inflammatory phase, wherein there will be pro-inflammatory cytokines, proteases, reactive oxygen species, and senescent cells, and the infection persists. Now, what happens is in a chronic wounds, there is high levels of these inflammatory cytokines and proteases and senescent cells, whereas the pendulum then has to move towards the left, wherein there's less bacteria, less inflammatory cytokines and proteases, and mitotically competent cells for healing. In the presence of infection, wound healing doesn't happen. This is explained by prolonged inflammatory phase, wherein all the above said processes happen we discussed earlier, but also there is disruption of the normal clotting mechanism. There is disordered leukocyte function and less efficient angiogenesis and altered granulation tissue formation. Obviously, the wound healing does not happen easily because of this spectrum of colonization, contamination, and critical colonization and localized infection, and obviously systemic infection. This is a spectrum that has been thought previously. The bacteria, if they present on the wound bed, if there is an excessive load of bacteria, then wound healing stops. Obviously, chronic inflammation causes problems, and then obviously there is altered host defense and cytokine production. Increased pathogenic strains can be present because of survival of bacteria, and also polymicrobial nature and biofilm resistance helps the bacteria continue to persist and be protective because of biofilm presence. And we need to do biofilm-based wound care for wound healing, and that could be because bacteria overcome host defenses. We need to understand the clinical signs of infection, which is pain, purulence, erythema, warmth, foul odor, and also presence of hypergranulation and friable tissue. Obvious cellulitis and osteomyelitis we need to be aware of. But all these signs of acute infections are kind of blunted in chronic infection, and also that is more blunted in patients who have diabetes, arterial disease, and elderly people. Suppressing the biofilm while managing these infections is very much needed, and single strategy will not help. We need to do different frequent debridements and different approaches to wound bed preparation, which we're going to talk more. Chronic wound tends to be because of inflammation, the wound bed gets stuck in, which we talked about because of elevated inflammatory markers of tumor necrosis factor, interleukins, and also because these neutrophils and cytokines are causing all these problems. We have heard a lot about TNF and interleukins with the current COVID crisis, but also these interleukins have a huge impact on wound healing. We need to understand that. And obviously, there is increased matrix metalloproteinases, MMPs, and elastases, and reduction of tissue inhibitors of MMPs, and there is increased reactive oxygen species. There is something that I came across, something called as thrombospondins. Researching for this lecture, I came across that, wherein it is also in depletion of thrombospondins is involved in clotting when pulmonary embolism or DVTs happen. So obviously, there is reduced growth factors, there is extracellular matrix degeneration and cellular proliferation that is reduced, increasing the chronicity of a wound bed and preventing the healing. So I was talking about quorum sensing. We talked about the bacteria talking to each other, gram-negative rods talking to each other using hormones, homoserine lactone. And obviously, what happens is initially the bacteria concentration might be low in the planktonic level, but when it goes to the biofilm level, the bacteria talk to each other, and through this language of using homoserine lactone. And obviously, the more the bacteria accumulate at one spot, then this triggers the metabolic response wherein the inflammation happens and infection worsens. Now, a non-healing chronic wound characteristically has multiple characters, but obviously it's hard to detect this problem. If there was any solution, a solution that shows increased proteases, increased inflammatory cytokines, increased reactive oxygen species, and increased bioburden, shows that, okay, the wound is not healing, but also the reduced growth factors, extracellular matrix, and reduced cellular activity predicts wound healing that is not going through the normal path. So obviously, we wish we had this solution, but it is not easily available. But also, we have to understand that it's not what you put on the wound, what you take off from the wound is also important. The wound bed by itself endogenously has macrophages, fibroblasts, and endothelial cells and keratinocytes, and also, but exogenously have bacteria and fungi. The chemicals that are involved are growth factors, cytokines, reactive oxygen species, but exogenously there are toxins that are also present. So what's the answer? Can we get new antimicrobials or improved antimicrobial stewardship or improved infection control? But also we need to figure out how we should prevent the chronicity by reducing bacterial biofilm and preventing it reformation. That's only when the healing would happen. Now, what are the methods? Debridement is the hallmark. It is a king of wound healing, and debridement methods that are multiple, including biological debridement, which biocides with larvae that are used, but ultrasonic debridement, surgical debridement, enzymatic debridement, mechanical debridement, and obviously topical anti-biofilm processes are very much important. So sharp debridement is very much needed to disrupt the biofilm process to predict outcomes. We need to know that we need to use different paradigms of debridement processes as much as possible and track the outcomes. Now, tracking is now also being used using new techniques with fluorescence imaging. When this is available, if we can deploy it, that would be amazing. But then we have to understand that there is certain bacteria that are not fluorescent too. So Enterococcus and Streptococcus are not fluorescent, but Pseudomonas and Staph aureus could be fluorescent. So obviously, there are different techniques, but close monitoring of the wound and evaluation is very much necessary. Now, conscientious guidelines were identified, and it were published in Wound Repair and Regeneration in 2017. And basically, this is a step down and step up approach. Step down is the initial approach wherein you do aggressive debridement, like I was talking about debridement being the king of wound healing. We need to understand manage the host factors, understand local and systemic antimicrobials, and also try to do different techniques of identifying microorganisms, including advanced techniques where available with DNA and also sRNA techniques, and also optimize the offloading and nutritional evaluation. and obviously optimize the host factors, reduce the inflammation, and continue to maintenance debridement. Once that stage is gotten to, then advanced therapies, including skin grafts, advanced combination products, including negative wound therapy, could be used. Um, Different biofilm products, including iodine and silver, interfere with microbial activity, and also polyhexamethyl biguanide, benzalkonium chloride, disrupt cell membranes. Hypochlorous acid interferes with cellular processes, but also surfactant is containing polyaxamer 188 is also there, and also electrical fields are being used to increase the wound healing process. Now, these biocides, they are different kinds, including antiseptics, and like we talked about silver and iodine, and the slow release of iodine, and obviously uh, biocides, and these are biocides. Obviously, gas hyperbaric is an important technique, and nitric oxide is very much needed. And endothelial injury happens because of bad problems with nitric oxide. Obviously, phage and bacteriophage products are also being starting to be used, and quorum sensing inhibitor, wherein the biofilms are prevented using hamilneck tannin, and furans are being used, wherein the quorum sensing is inhibited there, and matrix strategies, wherein surfactants are used, EDTA, and obviously benzalkonium chloride, and compounding gels are sometimes also used. So coming to the guidelines here, international working group guidelines are what we are going to discuss here quickly, wherein PICO format, patient intervention, comparison, and outcome are being used, wherein uh, for at least two of these should be present with erythema and local tenderness, and also purulent discharge. And when these two are present, this is mild infection. When three, it is moderate infection. Four of these are present, it is severe. But also, when there is osteomyelitis after from stage 3 or 4, then you add as O for it. So that means that there is osteomyelitis involved. Obviously, this 4 classification involves heart rate that is increased and respiratory rate that is increased, and obviously serious diabetic foot indications need hospitalization, and severe infection needs intravenous antibiotic therapy and surgical debridement processes, and antimicrobial therapies, including for mild infections. When the gram positives are present, you use penicillin or first generation cephalosporin, and gram negative rods, beta lactams are used, and MRSA, adaptomycin, Zyvox, vancomycin is used, and moderate to severe infections, beta lactamases, cephalosporins, and MRSA infection antibiotics are used. And when there is ESBL infection, you use carbapenems. Obviously, all these infections are present, but we need to establish registries and pathways, and to monitor, improve, and learn from different processes of antibiotic therapies. Now, the pathway for diabetic foot infection, this is complex, but you can look it up at the guidelines. But here is simple. When it is the patient characteristics are there, including neuropathy, we need to look at the local characteristics of the purulence or not. When there is mild infection, you follow this path, wherein initial antibiotic therapy, we decide whether there is going to be hospitalization. When it is a severe infection, then you go through the path of severe infection. And obviously, when there is mild infection, outpatient antibiotic therapy is used, and debridements, wound healing, adequate antimicrobial interventions are supposed to be used. Now, we have to understand that diabetic foot ulcers have 5 things to know. Reulceration rate is very high, almost 80%, with the 48% on the contralateral side can happen. And it is polymicrobial. 40% of the diabetic foot patients have peripheral vascular disease, and people with diabetes, 25% have incidence of diabetic foot ulcers, and spending on per patient is at least 26,000. I think it's a lot more than that though. And there is many controversies in diabetic foot infection. Should the clinicians monitor the patient to see when the infection is resolved, or what is the optimal duration of osteomyelitis therapy? Nowadays, they are saying aggressive treatment and 3 weeks of treatment is good enough. What is the treatment of diabetic foot infection in low-income countries? What are the imaging studies that are supposed to be followed? How can we determine that the residual or margin of the bone has been resected completely? And what is the best treatment for osteomyelitis? Is it medical or surgical? How do we take care of the bacterial bioburden? And what is the value of proper different microbiological testing, including the genetic genotypic testing or regular cultures? What is the controversy there is the mRNA testing versus regular cultures not identifying complete bacterial microbiome in the ulcer bed. And obviously, what is the role of topical and local antibiotic therapy? And presence of biofilm, how do we identify that? And what is the best way to treat? Now, I would be remiss if I don't talk about nutrition, but nutrition by itself is going to be another talk. But without talking about nutrition, I think I would be ignoring the elephant in the room. And obviously, it is a powerful tool that we neglect. Mostly, we don't talk about it and we don't look at it. Vitamins are very important, including vitamin A, which is when people are using steroids, or it is very useful. But vitamin B is very needed in wound healing. And vitamin C, obviously, we know the collagen formation is very much needed. Scurvy was what brought this into the prime highlight. But obviously, vitamin D has been noted to show, lack of vitamin D has been noted to show wound healing problem. And zinc and magnesium and copper are coenzymes in many enzymatic activities. And amino acids, we need amino acids for wound healing. And obviously, those can be gotten from a lot of protein intake. Obvious protein, macronutrients, protein, fat, and carbohydrates are the macronutrients, and proteins are needed for collagen synthesis and inflammatory cell formation and wound contraction. And vitamins are vitamin A, D, E, and K are fat soluble, but fat itself is a calorie carrier. And calorie restriction has a severe impact on wound healing, and stress produces cortisol and prevents a lot of healing and inflammation presence. Now, I put 2 lines through this carbohydrates, but because carbohydrates are not the calories that are needed for wound healing. In fact, we don't need carbohydrates because our liver makes carbohydrates that we need. Obviously, this is a controversial topic which we can talk about in a bigger picture. But metabolic syndrome and insulin resistance is stimulated by carbohydrate intake. So we have to understand and discuss. This is for a whole another discussion, which could be a long presentation of its own, which we can get on at a different date. So obviously, the second slide on nutrition I wanted to show is ketones. Enhancing wound healing in rats. Exogenous ketone supplementation promoted wound healing, and obviously helped with enhancement of physiological factors such as proliferation, advancing migration, and reducing reactive oxygen species, and increasing the blood flow in the rats. Supplementing ketones in this rat population was noted to be anti-inflammatory. And this was very much important. Finally, concluding this, we need to understand that biofilms are communities of bacteria encasing in a matrix of polysaccharides and DNA that provide high levels of tolerance for antibodies, antibiotics, and also antiseptics. Biofilms are present in high percentage of chronic wounds, and they impair healing. and steam and chronic inflammation is caused by them with elevated proteases, reactive oxygen species also. Biofilm we need to have debridement, local care, systemic treatments, and stepwise approach, step down approach to reduce the bacterial biofilm and killing the bacteria in the biofilm, and local care, and step up approach using proteases are very much step up approach with advanced therapies are very much needed to reduce the proteases. And obviously, wound healing is a multifactorial process. We need to understand that one person cannot do it. A systemic approach and a team-based approach with everybody taking responsibility and in removing barriers to healing is very much necessary. And I want to end this with a quote saying that all medicine is personal and every patient is a puzzle. And we ought to move away from the mass medicine mindset with the N of one approach to wound healing and also patient care. Thank you very much. And please feel free to contact me on social media if you have any questions regarding this presentation. Thank you very much.